Texas hospitals and ambulatory surgery centers have an urgent demand now for life-saving surgical smoke evacuation equipment to protect surgical teams and patients during electrosurgery. More than 500,000 U.S. surgeons and their surgical teams are exposed daily to the dangers of surgical smoke emitted by heat-generating devices. 95% of these devices, including electric cauterizing equipment, electronic pens, and lasers, produce smoke filled with toxic and pathogenic materials, as well as at least 40 known carcinogens as they cut, ablate, and suction human tissue.
Consider the perioperative nurses, the surgical technologists, and the entire surgical team endure as long as 12 hours a day, 3 to 5 days a week. Surgical smoke is emitted during orthopedic surgery, gastrointestinal surgery, gynecological surgery, cardiothoracic surgery, and during pulmonary procedures, as well as during plastic surgery and tissue ablation. Do you know what's carried in surgical smoke? Harmful gases, blood, infectious pathogens, surgical chemicals, and carcinogenic cell particles, and many, many more. And not only is the entire surgical team breathing harmful gases through the surgical smoke, but our patients, including newborn babies from C-sections, they too are subject to unabated airborne particles.
And what is the outcome for human victims of unabated surgical smoke? A survey of Texas surgical personnel reveals surgeons and their teams are suffering from lung diseases ranging from asthma to chronic obstructive pulmonary disease and lung cancer. Others are picking up the pathogens from human papillomavirus. Nurses and surgical technologists are going home with breathing difficulties, various forms of diseases including skin cancer. Working 10 hours a day, 4 days a week, I experienced frequent allergic rhinitis and
June, my history of the complex surgeries that have multiple surgeons operating on one patient have increased smoke evacuation hazards too. Here, multiple electrical cautery pencils are being used to create immense amounts of surgical plume. In my many years of practice in the military and hospital settings, I have had ongoing throat and eye irritation, as well as a significant amount of upper respiratory infection rates. Research has found that surgical personnel have twice the upper respiratory infections than anyone else in the hospital setting.
I agree. In my experience, though, when working in an operating room that uses a smoke evacuation system, there is noticeably cleaner air. Equipment is available to safely evacuate the surgical smoke and the deadly particles it carries. Surgical smoke is drawn into a suction tube, moved through inline filters, and contained in an air-sealed system, then disposed of according to stringent federal standards.
Surgical smoke inhalation cannot continue in Texas hospitals and ambulatory surgical centers. Smoke evacuation is long overdue.
Surgical culture must change. If Texas legislators act now, our state could be the third in the nation to pass a bill requiring surgical smoke evacuating equipment in every hospital and ambulatory surgical center. Rhode Island passed the first such bill in June 2018, followed by Colorado with House Bill 19-1041 in January 2020. 10 other states, including Georgia, Oregon, Tennessee, Kentucky, Utah, and New Jersey, currently have bills in process. The Texas collaboration of perioperative registered nurses, TCORN, in conjunction with the National Association of Perioperative Registered Nurses, AORN, is diligently working on changing operating suite culture through assessment, education, and resolute work. Our work must result in air quality safety for both medical personnel and our patients. Change is vital now. Texas nurses are leading the way. We ask you to join us in support of a bill requiring surgical smoke evacuation in our hospitals and ambulatory surgery centers statewide.